It's 2:17 a.m. in the morning. You've been asleep for maybe 40 minutes. Your pager goes off, and it's a nurse on 7 South. Room 714 has heart rate of 128, and she's running a fever of 102. You roll out of bed, splash water in your face, and start walking. Because you're the only doctor in the building right now for 12 surgical patients you signed out for 6 hours ago. And most of them you've never met before tonight. What do you do? If you're a fourth-year medical student, a brand new intern, or just about to start your first overnight surgery call, this video is your survival guide. We are going to talk about sign out, what to monitor, how to work up the most common overnight disasters, and critically, when to stop managing and start escalating. Let's start before you even step foot on the floor, the sign out. This is your everything for the next 12 hours, and a bad sign out will cost you at 3 a.m. For every patient, you need to know 5 things: who they are, their name, their age, their room, why they're here, their diagnosis, and what operation was done or what operation is being considered. What's their baseline? Because a heart rate of 95 means something totally different on a 28-year-old patient versus a patient with compensated heart failure on a beta blocker. Comorbidities matter. Diabetes, COPD, CKD, anticoagulation, immunosuppression, you have to know them. Fourth, what's the overnight plan? What's already been ordered? What's pending? What are you managing? And fifth, and this is the most important one, what do you do if they call you about this patient? If her hemoglobin comes back below 7, transfuse 1 unit. If she spikes, start the sepsis workup. Anticipate. The best sign-outs answer questions before they're even asked.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button, and let's keep on going.
If you're on the giving end of that sign-out, please be specific, be honest, and don't hide sick patients. All right, you've got your list now. Now, what are you actually watching overnight? Vitals first. Trends matter more than a single data. A blood pressure of 90/60 itself may mean the cuff is off, but a blood pressure trending down over 4 hours, that's a story. For your surgical patients, you want to know their baseline, and you want to be alerted early. This includes a heart rate above 100, a systolic blood pressure of 90, an SpO2 below 92, which is followed by a respiratory rate above 20. And lastly, urine output of below 0.5 ml per kilogram per hour. Urine output is your silent vital signs. Don't ignore it. For your physical exam, when you get called, see the patient. Do not treat over the phone unless you have no choice. Go see the patient. Assess the mental status. Are they with you? Assess the surgical site. Is there new erythema, warmth, fluxions, drainage? Is this making you suspect that there is an infection? Assess the abdomen. Is there guarding and rigidity, in which an overnight in a post-op patient is a surgical problem until proven otherwise? Listen to the lungs. Check the legs for DVT. Performing a complete physical examination and looking for clues and relating them to what the patient is presenting with is very important in order to form your differential diagnosis. Now, once you've started that progress, now you're into ordering labs and imaging for confirmation. Know what's pending from the day team and what you may need to add. A CBC matters in a patient with suspected bleeding. A BMP matters in a patient with AKI or electrolyte issues. Lactate matters when you're worried about perfusion. And a CAT scan, don't be afraid to get it if your clinical picture demands it, even at 3 a.m. The radiation is a lot less dangerous than the diagnosis you miss. Fever. You're going to get paged about fever constantly. The classic teaching is the 5 W's of post-op fever: wind, water, wound, walking, and wonder drugs. You can actually check out our video discussing post-op fever and its differentials. And now let's actually break it down. So day 1 and 2 post-op, you start with wind, and this is focusing on atelectasis from hypoventilation, which is the most common cause of early fever. Get the patient up, have them do a deep breath, and use incentive spirometry. Day 3 to 5, think about water. Do they have a urinary tract infection, especially if they've been catheterized? You can confirm this by getting a urinalysis with reflex to culture if necessary. Day 4 to 6, think about the wound. Look at your surgical site. And again, you always have to do your complete physical exam. But during this time, surgical site infection becomes increasing. Go look at the incision for cellulitis, fluxions, purulent drainage. And these are all your clues if we need to open the wound. Next one, think about walking, DVT and PE, especially a patient who's hasn't been ambulatory. If they're presenting with tachycardia with pleuritic chest pain and low-grade fever, you may end up needing to confirm that with an ABG looking at your AA gradient followed by a CT-PE protocol if your suspicion is high. Next class is going to be your wonder drugs. Are they having drug fever, transfusion reaction, or could they actually have C. diff? And you have to ask, have they been having diarrhea or previous antibiotic use? Don't forget C. diff. Always ask about diarrhea. Any fever beyond 24 hours that doesn't have an obvious cause. Your workup is blood cultures ×2, urinalysis and urine culture, CBC with differential, CMP, and consider chest x-ray. Then treat it empirically if indicated while you're waiting for cultures. Now, let's actually move to tachycardia and shock. Tachycardia overnight, this one needs to be taken seriously. The differential is long, but the ones that will kill your patient if you actually miss them include bleeding, sepsis, pulmonary embolism, cardiac tamponade or heart attack, and a chest surgery patient. Start with the basics. Is the patient in pain? Pain drives tachycardia. Are they volume depleted? Have they had adequate fluid replacement? What's their urine output been? Do they look pale, diaphoretic, or confused? If you have tachycardia plus hypotension, now you're in shock territory, and your approach changes. Think in 4 buckets: hypovolemic, distributive, cardiogenic, and obstructive. Again, we also have another video discussing shock. You can actually check it out. So, hypovolemic. Are they bleeding or dehydrated? You can actually check it with your labs using a CBC. You can also look at the surgical patients if they have a drain. Are they having bloody output? You can examine their abdomen. Are they peritonitic? Because blood irritates your peritoneum. And in the first hand, you can start them with ensuring that you do have 2 large IVs for access and start fluid resuscitation and see, are they responsive? If you are truly worried, you may actually start blood earlier. Next type, distributive, which septic shock falls under. They usually present with fever, warm extremities initially, altered mental status, hypotension, unresponsive to fluids. Because what happens is your vessels relax from the toxins secondary to the bacteria. You have to start the sepsis bundle. Obtain cultures, start broad spectrum antibiotics, fluids, and you may consider vasopressors. And you want to get a lactate that you can trend. Next case is going to be your cardiogenic. They could be cold, clammy with an elevated JVP, a new murmur, pulmonary edema, and exam. You may have to call cardiology or get an echo, and do not aggressively fluid resuscitate this patient. There's a lot of things that can cause cardiogenic shock or just issues with the heart in itself. Next case is going to be obstructive, which includes your PE, and you could also have tension pneumothorax that may present with tachycardia, hypoxia, and hemodynamic instability. You can start systemic anticoagulation if you confirm it, and you can consider IR or surgical intervention for massive PE. For tension pneumothorax, they may be presenting with tracheal deviation, absent breath sounds, and you have to look at it in aspects of what risk factors do they have to actually have this problem. And that includes chest surgery or instrumentation such as central line placements in the neck or the chest. When to call your senior resident. Do this early. Any hemodynamically unstable patient, they have to be aware. Any patient who has failed initial management, any patient where you're not sure what's happening. Anytime your gut says something is wrong and you can't name it, call your senior. That's what they're there for. You're not meant to do this alone at a PGY-1 level. When to transfer to a higher level of care. This is when coordination of care occurs. The attending on call is aware when you need to transfer to a higher level of care. If your patient needs vasopressors, they belong in the ICU. If they need continuous monitoring, mechanical ventilation, or invasive hemodynamic monitoring, they belong to the ICU. If they're on the floor and your interventions aren't working, they belong to the ICU. Call the charge nurse, call the intensivist, and start the conversation early. Don't wait until they're coding. So let's talk about when to call for help, because the biggest mistake new interns make is waiting too long. When to call a consult. If the problem is outside your service, get the right team. Next phase, when to consider taking them back to the OR. Again, you are at the point that you should have actually alerted your seniors and your attendings, because this is going to be above your head when to take the patient to the OR. This is your seniors and attendings' decision, not yours alone. But you need to know the red flags. Uncontrolled surgical bleeding, peritonitis, that's a surgical abdomen. Don't sit on it. An anastomotic leak with sepsis, compartment syndrome, a deteriorating patient with no clear medical explanation who just had an operation. If any of these boxes are checked, that's a conversation you need to be having right now. Look, overnight surgery call is hard. Nobody pretends otherwise. But it gets less terrifying when you have a system. Know your patients before the night starts. Watch the trends, not just the numbers. Work up the common problems methodically, and when things go sideways, call for help early, act fast, and trust your instincts. If this video helped you, save it before your first overnight call. Share it with your co-interns, and drop a comment below. What was your hardest overnight call experience? And subscribe for more practical clinical medicine, and check out our other videos, and I'll see you guys next time.